Ladies and gentlemen, welcome to another episode of MedSynapse, the podcast where we delve into the fascinating world of medicine and healthcare. I'm your host, Dr. Nigar, and today we have the privilege of hosting a distinguished guest, Dr. Adam Staron, an MD and a PhD. Dr. Staron is a consultant cardiologist with a decade of expertise in cardiac rehabilitation. Having earned the prestigious European Society of Cardiology training grant in Milan 2008, Dr. Adam's contributions to cardiac health are truly commendable. In 2014, he founded the Cardiac Rehabilitation Department in Katowice, pioneering innovative approaches by incorporating yoga and Tai Chi into rehabilitation practices. Notably, Dr. Adam extended his impact internationally, establishing the first exercise training program in the Kingdom of Saudi Arabia in 2018. His commitment to advancing the field is further highlighted by his role as the main author of the cardiac rehabilitation textbook called Exercise Prescription in Cardiac Rehabilitation, which was published by MDPI in 2022. Currently serving as the head of Cardiac Rehabilitation Department in Gliwice, Poland, Dr. Adam's leadership is instrumental in shaping the future of cardiac care. He also plays a crucial role as a board member of the Cardiac Rehabilitation and Exercise Physiology section of the Polish Cardiac Society. Today, our focus is on the intricacies of cardiac rehabilitation, exploring the latest advancements and insights with Dr. Adam Staron. Welcome, Doctor.
Hello.
Thank you so much for joining us, Dr. Adam. It's an honor to host you today on our podcast.
I'm fascinated and truly honored to join your podcast series. To be very honest, cardiac rehabilitation is underappreciated, and the problem is to popularize it as much as possible worldwide, especially that this is the cheapest and the best pill for the heart and for the whole cardiovascular system. And to be very honest, not every cardiologist realizes it. And the worst thing is, if we don't spread our knowledge, if we don't share our expertise, it's deteriorating and worsening our outcomes and our patients. So I think it's a good time to put the cardiac rehab into proper place.
Dr. Adam, to begin with, how crucial is cardiac rehabilitation in the overall management of cardiovascular diseases? And what specific benefits can patients expect from participating in cardiac rehabilitation program?
Well, your question is quite long, so let me start with the first part of your question. Cardiac rehabilitation remains the main pillar of the secondary prevention of cardiovascular disease. And what is very important, it affects positively our outcomes. Maybe you know, maybe you don't know, but cardiac rehab program reduces cardiovascular mortality by even 36%. The percentage of the unplanned hospital admissions reaches beyond 50%. In other words, it reduces mortality so significantly, total overall mortality and cardiovascular specifically, that this appears to be number one pill in cardiology. The cardiac rehab is a comprehensive program, so it includes initial assessment, optimization of pharmacotherapy in case of the patient who have implanted cardiac electrical devices. The optimization of their devices takes place. There is management of blood pressure, weight management control, lipid management, psychosocial support, dietary counseling, but still the core component remains exercise training. Cardiovascular rehabilitation is still based on the exercise training, so regular physical activity. And what we do, we prescribe effective formula, effective parameters of training, individually tailored plan for every patient to finally affect their mortality reduction and their benefits, and to increase the quality of life, to affect metabolically. Not even every cardiologist knows that training itself, regular training on specific intensity, reduces arrhythmia. This is not uncommon that we see the patient with bigeminy, trigeminy, so complex ventricular arrhythmia. And when the people start to exercise, it disappears. I mentioned already, the blood pressure and weight, but also glucose level, insulinosensitivity increases, insulinoresistance decreases. So it's people don't need so much insulin like before. Quality of life improves because of endorphin are released. Of course, fitness improves, both aerobic, so cardiorespiratory, and musculoskeletal. So people are stronger and more fit. And I think it's, in short, all beneficial effects. By the way, what is also very, very important, even patients without full revascularization, cardiac patients with coronary artery disease, but not treated by PCI, by percutaneous coronary interventions, or because it's alternative coronary artery bypass surgery sometimes. So those who cannot be who cannot undergo percutaneous or surgical treatment, so they are not revascularized. Even in these cases, these patients, by regular physical activity, by properly prescribed training, you can increase their ischemic threshold. In other words, they will exercise without angina, without chest pain. So from my point of view, this is the cheapest and the best cardiovascular pill ever. And people should just decide and clear their minds and decide to take it. And that's all.
Dr. Adam, I definitely agree with you. Cardiac rehabilitation plays a very important role in managing the cardiovascular diseases. It's not just about recovery, but it's also about empowering the patients to actively participate in their long-term well-being. Now, moving on to our next question, could you please share insights into the evolving role of technology in cardiac rehabilitation? And how are digital tools and remote monitoring impacting the ways patients recover from cardiac events?
Oh, this is truly fascinating topic, Dr. Enigar. To be very honest, I should add one more comment regarding the previous question, because you should know that on average, cardiac rehabilitation decreases your biological age by 10 years in men and around 12 years in women. At our center, we have even much more impressive numbers. It's over 20 years. So in other words, patient after a few weeks of the training gains fitness of person 20 something years younger, over 20 years younger. So they don't come back to the status before MI, before myocardial infarction, or before a problem, but they are going deeper into their young years. So it is very, very fascinating to see people being better, more fit than their children, for example. Regarding your question, artificial intelligence and technology gradually takes over all fields of medicine and also cardiac rehabilitation. In the past, we had pedometers, accelerometers, facilitating training at home. Nowadays, with the approach to the and availability of all applications, mobile phones, smartwatches, smartphones, and numerous applications, you can track your activity, heart rate, you can track the distance covered, and what is very important, volume of exercise, so energy expenditure way, measure distance covered, and combined with the speed, it's volume, so it means your kilocalories burned. So we have some recommendation to burn at least 2,000 to 3,500 kilocalories per week. So patients can adjust their, activities to fill this number. And what we do more, telerehabilitation, hybrid rehabilitation. So remote cardiac rehabilitation is also advanced solution. People are connected with the monitoring center through mobile network, and they have devices who can show their ECG trace via Bluetooth from their precordial leads, so chest leads ECG, to the mobile phone. In other words, you can be very far from your patient and supervise her or his exercise training. So the machines, newly developed machines, by sound or by lights, show active, passive phases, so recovery and work. And if you have your individually tailored home program, being at home, you can exercise, for example, because you live far from the center, or because of, for example, traffic, and you cannot reach your cardiac center, or this is unavailable, or you are older person, or you have financial problems with commuting, or with, regularly taking part. So you can do it from home, just utilizing simple device, which will be connected via a mobile network and transferring the data to your monitoring center. What doctors and physiotherapists are asking is just they have to have direct connection to check clinical status on this day. Then they check blood pressure and weight, and resting electrocardiogram is transferred. It's also possible to have ECG live transmission, and then patient starts to following commands to perform exercise. Of course, it requires some session supervised at the facility, so it can be outpatient or residential cardiac rehab, but then patient follows their program at home. So from my point of view, it's time-consuming and cost, cutting, a low-budget solution, very effective and very safe. A lot of multi-trials have been conducted, randomized trials, showing non-inferiority of the home-based cardiac rehab in comparison to supervised. Of course, always you have start with supervised program. So as you see, cardiac rehab is following the requirements of current times, and cardiac rehab also can be done like IT mode, approach by artificial intelligence and IT solutions allow to take part in the training remotely. With sensors and with detection of all your vital signs and the most important parameters. By the way, there are a lot of applications you can find probably all over the world supporting exercise training led by professionals or coaches and fitness sports, or by physiotherapists. And at least in my country, in Poland, I know 2 or 3 applications. People in a very safe and effective way can perform their exercise training. I'm talking about cardiac patients. I'm not talking about general population, because numerous, application exists for the cardio training of healthy people. I'm talking about cardiac patients. So nowadays, this is a big revolution behind us, and applications, mobile phones, smartwatches and smartphones can facilitate exercise training. And they can calculate your training heart rate based on your risk. Of course, you shouldn't forget about presence of the exercise professional, and in this case, about presence of cardiologist at the beginning, because your risk should be stratified, and first few sessions should be always supervised and ECG monitored.
Dr. Adam, thank you so much for giving us an interesting and a detailed overview on the evolving role of technology in cardiac rehabilitation. It's truly interesting to see how digital tools and remote monitoring impact the way how patients recover from these cardiac events. Moving on to our next question, what are some common challenges or misconceptions patients have about engaging in cardiac rehabilitation, and how can healthcare professionals address and overcome these barriers?
Very good question. Thank you for this question, because especially misconceptions in cardiac rehabilitation can deteriorate patient status. Okay, so let's start from challenges, because you mentioned challenges first. The biggest challenge is unavailability of cardiac rehabilitation centers. 70% of world has already cardiac rehab, but there are still regions like Middle East, for example, or North Africa, with very small number of centers. There are still countries without cardiac rehab. So the biggest challenge is to develop it, at least in the modified, simple way. So, for example, at least to write recommendations, cardiac rehab recommendations with minimal standards. For example, I'm a co-author of the guidelines for Kingdom of Saudi Arabia. And what we did in case of Saudi Arabia, because there is still only just few acting cardiac rehab center. I had a big privilege and big pleasure with my team to establish cardiac rehab in the military hospital in Riyadh. But this is 40 million population country, and it requires at least 60, 70 such departments or units. So what we did with cooperation and collaboration with Saudi Prevention and Cardiac Rehab Group and Professor Abdul Halim Kinsara, we have written the guidelines with separate minimal and maximal, optimal standards. So if you have facility with budget and you can afford to buy expensive equipment for professional training with ECG monitoring, you should fulfill the optimal standards. However, if you cannot afford this cost, or this is very small city, let's say north of Saudi Arabia or south, and they don't have even sometimes cardiac department nearby, what you can do is at least implement the minimal standards program with 6-minute walk tests, some rough estimation tests on admission. So very rough assessment, but this is much better than nothing. And even low intensity exercise always will be better than a lack of exercise. Number 2, you mentioned challenges. Financial cost. There are places without reimbursement, so people don't attend because they have to pay. It shouldn't be like that, because they should have insurance covering, all costs of cardiac rehab. This is class 1 indication. In many diagnoses, post-myocardial infarction, post-cardiac surgery, it is class 1, must be. You have to implement it. If you don't implement it, this is error, this is mistake, this is something wrong. If doctors cannot recommend and refer the patients, it's very miserable situation. I really feel for this patient with risk factors who cannot attend cardiac rehab. So at least, some knowledge given to them can allow them to, they can exercise at home on condition this is very clearly written what they can do, what they cannot do. Regarding other challenges, there are disbeliefs. This is, by the way, also part of your sequel of your question, this misconception. There are still regions when people think that exercising is harmful, that better for example, after heart failures decompensation, to spend time at home. By the way, guidelines 20-30 years ago, written 20-30 years ago, clearly stated that exercise training in heart failure is contraindicated, but it changes still, and it has changed 20 or 30 years ago by 180 degrees. Just opposite, if you had episode of the heart failure decompensation, and when you stop to use intravenous medication, when your weight is stable, after a few weeks, you should start exercise training, because, for example, of your muscles. People with heart failure have sarcopenia. They have very weak muscles. They need to start training. They have very low fitness. If they don't exercise, their oxygen uptake will be lower than it was before. In other words, one of the misconceptions also among doctors, especially old doctors, is if you have heart failure, don't move. This is not true. It was true 20-30 years ago. Now, concept is totally different. Of course, you cannot exercise during acute phase, but after a few weeks of stability, you have to exercise. This is 1,000,000% safe and effective way of treatment. So this is the biggest challenges from my point of view: lack of unavailability of the centers, lack of the centers in some regions, and second, misconception in the intensity. I will tell you more, Doctora. Can you imagine that there are still some countries with very well developed cardiac rehab program, like United Kingdom? So in UK, the program is very, very well developed, but they realize their improvement is just half MET, whereas average is 1.5. And each MET affects in several % of mortality reduction. In other words, patient from UK with 3 times worse outcomes will have 3 times bigger mortality. So they have to change all system. So why? Because probably they have only 1 day weekly supervised, and on the remaining days, they allow people to exercise at home. Unfortunately, people will be always better motivated seeing you under your supervision than at home. At the beginning, later, you can continue with home-based exercise, it's very effective and safe. But if you start from the beginning with just one visit weekly, the people probably will not follow you in proper way. So this is, from my point of view, one of the biggest challenges and one of the biggest misconceptions and misbeliefs. When I started cardiac rehab in Saudi Arabia, women were not allowed to bike without supervisor, male supervisor. Now the situation changes, so the access to bikes among women in gyms, at the gym for example, increases gradually, and you can meet women biking outside. The problem is with abaya, for example, and traditional Muslim clothes. So you have always considered everything, original tradition with due respect to this, and current guidelines. So you have to find sometimes solution combining with respect to the local tradition and culture, but allowing people to get healthier. I think that's all. There is probably much more, the misconceptions, but these are the most pronounced and the most visible I can imagine now. So lack of availability, lack of remuneration, lack of reimbursement, and also with some people, also from the healthcare, lack of, appropriate knowledge within medical society. By the way, also patients sometimes are stubborn. They are unaware, but they are also lazy, or they don't have good attitude. But you can work on them. I think even the laziest person will be exercising if they will follow you, if you show them, set them the example, and if you show them the beneficial effects.
Thank you so much, Dr. Adam, for sharing these excellent points on the importance of addressing the patient concerns. Even some patients may fear that exercise after a cardiac event may be harmful, or they may have misconceptions about the intensity of the program. Now, moving on to our final question for the day. Dr. Adam, given the advancements in personalized medicine, how do you tailor cardiac rehabilitation programs to individual patient needs and preferences? And what role does patient education play in achieving successful outcomes?
Wow, I'm very happy with this question. You unintentionally touched my very, very favorable point of the cardiac rehab. Doctora, there are 3 pillars of the exercise prescription. There is testing, then you have to transfer the data from testing to training, and finally you should set the good program. But the last stage, it's indefinite. So people are leaving your hospital, your unit, your clinic, and they should exercise on their own. And this challenge is the biggest challenge, how to motivate them and how to make follow-up exercise training. And one of the solutions we developed in Poland, I developed it also in my hospital, is mandatory exercise prescription on discharge. In other words, patient gets not only discharge summary, medical report, but they are given and they have very clear, very detailed instruction based on their testing on discharge, how to exercise, training heart rate, load, progression by time, progression by load. In other words, they are given the piece of paper with prescription for more than 1 year, for I would say for indefinite prescription based on their discharge exercise test. And such a paper, such a discharge summary, in my opinion, should be mandatory worldwide. Unfortunately, most of the cardiac rehab centers, they don't give any specific prescription. They just write general comments on regular physical activity. Patients deserve both general rules of training, including warm-up, cool-down, and main phase, and they deserve for very detailed prescription. If we treat cardiac exercise like cardiac pill, every pill has dosage from 2. You can up-titrate the dosage, you can increase gradually based on some rules. The same relates to exercise. I treat exercise like pill, I treat exercise prescription like medicine prescription. So I'm giving frequency, intensity, time, type, and volume, total volume and progression. So we comply with the Fit VP formula by American College of Sport Medicine, which is for the athletes. But for me, cardiac patient after cardiac rehab can be like healthy young person, so he can also be athlete. Based on that, if you apply high intensity training in form of intervals, it's proven that it prolongs life and it strengthens the muscle. Left ventricle is contracting in more vigorous way when you as a patient have to do higher intensity exercise. It's really safe because you start with the test, so you know the ability of the patient. Then you apply just some percentage, but high percentage. And it ensures that it's safe, but it's efficacious. And to be very, very honest with you, as I mentioned to you that we have outcomes reaching 3.3 meds, so it's over 20 years improvement. So people are over 20 years younger after 3 weeks of training at our center, which is much more impressive than in the literature. And they really behave like that. Not only because treadmill speed and inclination cannot be in a false way, increased. The result is not unbiased. But the problem is not this. The problem, if you give them prescription, they will continue. For example, this is general statement, exercise most of the days of the week. I don't like it. What I'm doing, I'm prescribing 2 days on, 1 day off, 2 days on, 1 day off. This 1 day off, on the third day, makes full regeneration of the body. By the way, in my opinion, the same should relate to work. We shouldn't have 5 days working week and 2 days together. Much better from physiological point of view is going to work 2 days and rest, relax on the third day. This is much more physiological. 66% of time for work, 33% of time for the rest. So what I do, I prescribe individually tailored program, and patient can choose bike, stationary bike or normal bike, walking, jogging, treadmill, Orbitrek, swimming, activities suitable and chosen by patients and myself. So this is one of the examples of the individually prescribed exercise.
Dr. Adam, a heartfelt thank you to you for sharing your wealth of knowledge and expertise on cardiac rehabilitation today with us on this important session. Your dedication to the field and commitment to improving the lives of those affected by cardiac problems is truly commendable.
Thank you so much, Dr. Miguel. Thank you.
Thank you so much, Dr. Adam. And we're definitely looking for many more podcasts together on our MedSynapse platform. And to our audience, your engagement is crucial in our podcasts. Thank you so much for your time and for joining us in this ongoing conversation. Until next time, goodbye.